Okay, hello and welcome to TMA's Myositis Research Webinar Series. This is a new offering that we are doing where every other month we will highlight the research work of a research in the myositis field. And today we have the honor of speaking with Dr. Victoria Werth. I'm Rachel Bromley. I forgot, I normally say who I am. I'm the host and TMA Senior Manager of Patient Education Support and Advocacy, but it's not about me. It's all about Dr. Werth today. She is a professor of dermatology and medicine at the Perelman School of Medicine at the University of Pennsylvania and chief of the Division of Dermatology at the Philadelphia Veterans Administration Hospital. Dr. Werth earned her degree. Sorry, it's not letting me scroll down. Earned her medical degree from Johns Hopkins University School of Medicine in Baltimore, Maryland. She completed a residency in internal medicine at Northwestern Memorial Hospital in Chicago, Illinois, and dermatology residency and immunodermatology fellowship at New York University School of Medicine in New York, funded by the NIH and Dermatology Foundation. She joined the faculty at Penn in 1989 and has developed an internationally recognized program in autoimmune skin diseases. Dr. Werth also serves on TMA's Medical Advisory Board. Dr. Werth, welcome and thank you for being here.
Thank you for having me, and I look forward to giving this talk. And just to start, we're going to be talking about research in dermatology. This is a broad topic. We've been really working in this area because we have the desperate need for new information and new approaches. And so that's really been the goal of the work that we've been doing.
Okay, one moment, Dr. Werth. I just wanted to let everyone know that if they have a question while you're doing your presentation, they can put it in the Q&A box, please. All right, go ahead.
Sure. And these are my conflicts. I do collaborate with industry, and I look forward to doing that because that's how we're going to get new medications. And in addition, I'm as was mentioned, I'm on the medical advisory board for the Myositis Association, and I work in a number of different ways within the dermatomyositis community. And we do some translational research and more basic research, and we'll talk a little bit about some of these different aspects of the program that I run at the University of Pennsylvania. We've been involved with some trials, including initiating the CV2 agonist trial, which we'll talk a little bit about some of those results and the implications. And this was funded by Corvus and also NIH. We'll talk. We are a site for the anti-interferon beta trial, and we are a site for the sub-Q IVIG study. And we are also becoming a site for VALOR, which is the TYK2 inhibitor study. And these are there are many other studies in the pipeline. We'll talk about some of them today. So first, to talk a little bit, my focus a lot is the skin. So I hope that's okay with you guys. And we, a lot of questions come up about how commonly do we see amyopathic dermatomyositis. And in my practice, it's about 60% of the patients that we see, so it's very prevalent. When you look at some of the older literature, including this study from the Mayo Clinic, which was looking at the Rochester database, they came up with about 21% of people with dermatomyositis having clinically amyopathic DM. But I'm going to tell you today about how hard it is to make the diagnosis, and that it could be anywhere a range of people, what percentage of people have this part of the disease. And we've done a lot of work thinking about diagnosis and classification. I'll just touch a little bit on that. One of the things is just to talk about the skin findings, which is the erythema over the papules and over the joints in general. And then other things such as the heliotrope, the erythema around the eye, looking at the cuticles, both because of periungual telangiectasias and dystrophic cuticles, and photodistributed violaceous erythema. Then there are many secondary changes that can happen. And so it's really the mix of so many different presentations that I think makes it very challenging sometimes to make the diagnosis. So we did one study that we published that we wanted to look at what the incidence was of skin findings, specific skin findings in this column here, in patients who had either classic dermatomyositis or clinically amyopathic dermato. And what you can appreciate here is that there was almost no difference in the skin findings between these two parts of the disease. And that's really important because for a long time, the clinically amyopathic DM patients were not able to be diagnosed or really properly treated because they were not considered to be almost in the same category of dermatomyositis. And so it's really helpful, I think, to see that when you systematically look at things like the erythema over the joints or the malar area or periungual changes, it's the same for both of these disease states. And this is just to show you what we were looking at when we looked at that distribution, but on the face, extensor surface, the bright red erythema. This is Gotrins off the hands, on the elbows, the Shaw sign. These are all aspects of the disease that are really differentiating and help us make the diagnosis. You can get ulcers, which we see in particular with MDA5 disease, which has been studied extensively. This is looking at mechanics hands, which is something we see also as in a morphology and helps describe patients who have dermatomyositis. This is the erythema, bright red over the joints that we see, and also the changes around the nail fold. So these are all things that we can find. Now, one of the studies that we've been working on that we presented not so long ago was looking at the nail fold. And so if you take like a magnifying glass or a dermatoscope and you look at what happens in the nails, there's a lot that goes on in quite a number of patients. I'll show you just how many. But what we often will see are these dilated blood vessels here. And we can see some hemorrhage here as well as some dilated vessels. We can see, again, more hemorrhage here. Some areas where there's dropout of vessels. And these are all things that we see quite frequently in dermatomyositis. So one of my students in the past year did a lot of work to look at many different patients with dermatomyositis from the standpoint of what the findings showed. And you can see, for instance, that looping that I showed you, I'll show you right here, this kind of looping that goes on is seen in about 77%, a lot of people who have dermatomyositis. And it can be a real good clue. But some of the other morphologies that I showed you, the hemorrhage is in like half of people. So this is something to really keep in mind in terms of, a physical finding that can be very helpful, but I think really requires understanding a bit better. The other thing to mention is that if we look at those who have high skin scores, so the higher the skin score, the more likely there is to be this abnormal finding on the nail fold, including this morphology that's different, capillary dropout, and less density of capillaries. And so these are all things that we see more, again, in patients who have worse skin disease. Now, we've done a lot of work looking at inappropriate activation of the type 1 interferon system. And this is looking at a biopsy in the right upper corner here, taken from the skin. And a biopsy can be very helpful in making a diagnosis of dermatomyositis. And what we see are basically what we call interface dermatitis, the lining up of cells along the dermal epidermal junction. We see blue cells here are inflammatory cells in the skin. And we've been doing a lot of studies to better understand what these cells make, what are these cells, and if you stretch the skin, why do we see more, the Gotrins, the erythema over joints? And there's a lot of work that can be done just looking at skin histology and even more scientific ways to try to understand what's going on in the skin. So we've looked and found many different, and I'll show you some examples of many different types of inflammatory cells in the skin, from dendritic cells to macrophages. These are all different names of cells, but they are involved with inducing keratinocyte cell death. And then you get release of parts of the skin that can then stimulate the immune system. And so trying to understand this cascade can be really important in terms of understanding what cells are there, what are they making, why is that important that they're making certain things, and how do we prevent those things from causing disease. So this one thing I do want to mention, though, is that as much as we do the biopsy often and find this interface dermatitis, we can't tell the difference between lupus and dermatomyositis. And that's a really important finding because it means that a lot of times when the biopsies get read out as interface dermatitis consistent with lupus, somebody might actually have dermatomyositis, but because of the way the biopsy was signed out, they're called lupus. And this gets to be very confusing for patients and can really delay the diagnosis. So it's often, again, interpreted as showing lupus just because people think that lupus is more common than dermatomyositis. So why do we have such a problem with the diagnosis? So it turns out that the Bowen and Peter criteria that were published in the New England Journal in 1975 really focused more on muscle. So if you look here, if you had a typical skin rash, you could not be called dermatomyositis because you had to have another criterion, and all these other criterion were muscle criterion. So that led to not being able to make the diagnosis of dermatomyositis because the criteria didn't work for people who didn't have muscle disease. So, and so there are other reasons why it's difficult, is that often people with dermato can meet the criteria for systemic lupus. And so we've worked really hard to define in different studies what percentage of people actually get diagnosed with dermato and when they come to our practice at the University of Pennsylvania. And what this is showing you is that of the people that we find have dermato, only about 44% were called dermato prior to coming to the university. And they were given other diagnoses. And I'm sure many of you have had the same experience of being called lupus or undifferentiated connective tissue disease, or even some other disease. And so that's very frustrating because the treatments for these other diseases don't always work. And so it's really important to think about how do we make a correct diagnosis. So I got very involved in some studies that were going on to try to develop new criteria, which I think was really important. And they were led by Ingrid Lundberg, who's in Sweden. And essentially what we were trying to do when we were looking at the criteria was to emphasize the importance of being able to include skin patients in the family of dermatomyositis, in knowing that it's part of the disease. And initially, the feeling by most of the people that were on the steering committee for the criteria project was that this is so rare that we couldn't really consider it. And so that forced me to go back and look at 3 years worth of CPT codes. And that's a way of coding dermatomyositis in the medical record. And so what you're seeing here is that many of the people that I saw in dermatology, in fact, about 70% had very little muscle. It was mostly skin. Whereas in rheumatology, at the time we did the study, it was mostly muscle patients, and they only saw 1 amyopathic and 2 hypomyopathic in 3 years. And so this meant that potentially other fields were seeing these patients, or that these patients weren't getting diagnosed. And so as a result of this study, it led us to be able to then begin to think about how do we include our patients who have skin disease in the diagnostic criteria so that we can properly diagnose. And I'm happy to say that at the end of this, and again, I want to credit a lot of work that Ingrid Lundberg did here. We now have 3 skin criteria that are used to define that if you have 2 out of 3 of these, then you can be diagnosed with dermatomyositis. And we have done additional studies looking at our patients with dermato, and found that of the patients with amyopathic DM, these new criteria allow finding a little less than 3/4 of the patients who are diagnosing properly using criteria, but the criteria are really for classification, not for diagnosis. But the goal would be maybe to even be able to capture a little bit more with classification criteria into this category, of dermatomyositis. So I think this is a really important to be able to try to do this. And so we actually have ongoing studies now studying patients with skin disease and dermato to see if we can include more skin variables that will allow capturing a few more patients into the classification criteria. So much of the work that we've been doing has been looking at the cells and the signaling pathways in dermatomyositis. And this is not our work. This was work that was done actually at Stanford and in collaboration with industry to show that in skin, blood, and muscle, there are certain interferons, interferon beta, which is a type 1 interferon, and interferon gamma, which is a type 2 interferon, that correlate very much with activation of interferon-induced genes. And so this is important because, and I'll show you why we think beta and gamma is important, is this is looking at a score in the blood for a number of genes that are upregulated with by type 1 interference. And the higher the score, the higher the genes are upregulated. And then this is looking at a specific transcript, for instance, interferon beta. So we're looking at how much interferon beta there is, and this is looking in the skin. And you can see that with more interferon beta, there's a higher interferon score, and there's like a linear relationship. So that means that this is an important cytokine in many patients who have dermatomyositis. And you can make the same conclusion here, where interferon gamma also linearly correlated. So the more interferon gamma, the higher the interferon score. And what we found, though, with interferon kappa and alpha was that there was no correlation with the score, and therefore it seemed that this was not as much of a driver of the type 1 interferons that were and type 2 interferons that were seen in the skin, namely interferon kappa and interferon alpha. So we did some work staining cells in skin in my lab, where we looked at myeloid dendritic cells stained with CD11C and also PDC stained with CD123. So these are ways you can use cell markers to specifically pull out certain cells and identify cells that are in the skin. And what this is showing you is that many of the cells in the dermatomyositis skin are more of the myeloid lineage staining with CD11C than with the PDC CD123 staining cells. We don't see so many cells here in the brown, many more here. And you can actually count the cells and kind of get an idea of what cells are here. So here's CD11C, that's quite a few relative to these CD123s. So this kind of work is very helpful. And we've now coupled that with doing tissue mass cytometry, where we can use many different antibodies at the same time, looking at what cells are in tissue and also what pathways are upregulated and what the specific cells are generating, are making. And you end up with a wheel here that shows you which cells are prevalent in the skin. These are, again, the macrophages and the myeloid DCs. We talked about the CD111, the CD11C. And you can also see, for instance, which pathways are elevated and define the pathways. And we're doing that here with, what are the signaling pathways that are increased in these cells. So you can get really drilled down and get a lot of detail with this kind of methodology. And this methodology is getting more and more refined over time, and is going to tell us a lot about this disease. So we also know that when you block, for instance, some cytokines like TNF, you can actually get higher amounts of interferon, and that can trigger dermatomyositis. So understanding the cytokines and their role is relevant to thinking about what drugs you might want to use, but also which drugs might be a problem, such as a TNF inhibitor, which might actually make the interferon worse. We wanted to mention, and I think this is a lot of work that we've been doing lately, has been why we have the impression that there is more dermatomyositis. It's hard to prove that because there can be certainly referral bias in that. But we like to think, what are some of the triggers? We know that genetics are really important, and that people who have dermatomyositis often have genetic autoimmune genes in their family history. But we also feel that once you have those genes, there's certain things that can be triggers for some people, not for all people. And we identified one of them with isolene. We had a number of patients who were taking isolene and either got newly diagnosed dermato or flared their dermato. And so we try to advise people based on the studies that we've done in the lab, where we can show that this can actually activate the cells to make more of the inflammatory proteins. We really think that's important to try to avoid those when you have the disease. We actually did studies where we took cells from patients with dermatomyositis from the blood, and we're able to put this isolene on in a dilute kind of way, and then stimulate the production of these proteins that are very similar to what we know are present in the skin and seem to be correlating with the activity that we see in skin. And so we've also been able to look at what pathways may be activated to cause the production of these proteins. So I think, again, it's important to realize about that what you ingest, even if it's not medications, can be really important to think about. And that brings me to herbal supplements, which I really think is a growing amount of evidence that these can really cause problems in dermatomyositis. And I think it's important to avoid spirulina, which is in a whole bunch of foods. It's in sometimes smoothies. You have to know what's being put into smoothies if you're not making them. Blue-green algae, chlorella, elderberry, echinacea, alfalfa. These are all things that can stimulate the immune cells and then lead to upregulation of those inflammatory proteins that can cause problems. So one of the studies that we did was to look at patients that we had in our practice who had either dermatomyositis or autoimmune blistering disease or lupus or just healthy controls. And what this is showing you is that there was a lot more herbal supplement use in people who had dermatomyositis. And that just may mean that there's something predisposing when you have the tendencies to dermato that this may actually be something that can be a bit of a trigger. And when we looked at spirulina, we found the same thing, that there was a much more use in dermato patients than in lupus or blistering disease or controls. So we do advise people to really read about what you're taking in terms of herbs, because they're not all the same, and some of them might be okay and some of them aren't. I'll mention just briefly about the COVID vaccine, which is, we think, very important for people to get, but it's also important to study if there's any problems with it. And so we did a very systematic study for about a year where we saw patients, we asked them what vaccines they used, what their responses were. We found out the manufacturers, the vaccine dates, and did they develop symptoms after the vaccine. And this is something that can only really close to the time that a lot of people got vaccinated, because after a while you can forget about the time course and any association. But what we did do was we studied about 400 people, 402 actually, over the course of the year, who had different autoimmune problems. And as you can see, quite a few had dermatomyositis, some had lupus. We're able to show that the patients who were vaccinated, who thought they had some mostly flares and not really new onset, although we did see some new onset in the setting of getting vaccinated, more of an issue in dermato than in lupus, and that there were some flares, most of which were controllable with treatment or with no treatment. But it was more in Moderna than we saw with Pfizer. And is usually what we found was that it was after the second dose. So about 82% of the patients who had symptoms had them after the second dose, not after the first and not after the third. So a lot of people have gone on and had many more immunizations, and they've done fine. But it's, I think, important to understand, and this is true for other vaccines also, that there can be, sometimes it can tickle the immune system and upregulate. So there have been cases of DM also associated with COVID infection itself. And so that's one of the reasons why we think it's really important to get vaccinated, because COVID can be a trigger for flares of DM or new onset dermato as well. And the exacerbations that we saw were mostly mild and managed with slight and brief increases in medication, or maybe nothing at all, and gradually settled down. But so on balance, we advise use a COVID vaccine, but to be important to be aware of potential exacerbations in a minority of people, and to bring that to the attention of your physician if that should happen. So there are a number of antibodies that have been studied, and this has largely been work that's been done in Stanford. And I just wanted to mention, because this is important in terms of just a lot of the ongoing work related to skin in dermatomyositis. But looking at antibodies can be predictive of potentially some of the complications and also some of the therapeutic strategies. And I think that's going to maybe be true more in the future than it is currently, because right now there's still some issues about how, getting accurate labs and everything like that. And I'll show you a little bit of data that we've done with that. But first, I want to tell you that these antibodies, and you probably recognize a number of them, I'm not going to go into them too much detail, but they can tell you a little bit about, is it more likely to be a skin problem, a muscle problem? How responsive is that person going to be to therapy? Are there ulcers? Is there more likely to be lung disease? Is there more likely to be cancer? I will emphasize that, most people that I see with TIF1 gamma do not have cancer, so I call it the worry antibody. But it's just worth knowing that these antibodies can be sometimes helpful. And we know, for instance, with MDA5 that you get ulcers, you can get this kind of mechanics hands. And these are some of the associations you see with the lung problems, the rapidly progressive ILD. And this is all important to understand, again, because it can be potentially predictive. And then there are other skin morphologies. And one of the confusing things about dermato is why the skin looks so different in different patients. Some of them seem to be more characteristically different. For instance, with here an anti-Interferon gamma, where you get some scale here, you can see the white scale, you can see papules here, and almost looking like psoriasis. So studying these antibodies may help us understand more about the phenotypes of the disease. And so that can be also really helpful. We did a study that looked at about 378 patients at Penn who had gotten a myositis panel. And then we went through the charts, I should say, a number of fellow, Dr. Candiga and also Dr. Zhang, who's also now a dermatologist at Penn. And they looked at the charts, and we sat down and went through charts where there was some confusion to make sure that we knew who had definite dermato, poly, or clinically amyopathic DM. And the reason I'm showing you this is to show you how it's not so common to get these antibodies. Only about 14% in this study that we did a while ago. And this is myositis specific, and this is myositis associated antibodies, about 21%. But most people really in our population did not have antibodies, and that's still true now. Although the antibody tests are getting a little better, there's still a lot of work to do to make them more sensitive, more predictive, and there may well be patients who don't have antibodies but still have dermatomyositis. So the use of commercial antibody panels has increased. There's substantial differences in how the lab tests are performed in different places. And we find that the myositis-specific antibodies are found in really a minority of patients that we see with myositis, although the numbers may be increasing a little bit lately. So I want to move on and talk a little bit about therapeutics, because this is all, I think what everybody wants to know is how are we going to do better with how we treat patients who have dermatomyositis and who have the skin part of dermato also. So we spent a lot of time developing and validating a disease severity tool called the CDASI. And this has to do with how much activity and how much damage is in the skin in a number of different body surface areas based on, for instance, the amount of erythema, and whether there's scale, and lichenification with thickening of the skin. And then at the end, you get an activity score and a damage score. And we know what the score has to be for moderate to severe disease. And we've done a lot of studies to look at how important is this response. So when we've looked at the CDASI response, we know how much improvement you need to get to have it important to patients. And this is a study that we did looking at the quality of life by using an emotion score that's done with a quality of life measure. And we looked at visit 1 and visit 2. And what this is showing you is that when people had a significant improvement in their skin score with the CDASI, the emotion score went down a lot. This is a big drop, and the patients were doing much better in terms of their quality of life. And so we would like to think that when the activity gets better, the quality of life gets better. And so that's what this is showing. But what this is showing on the right here is when you don't have a response, then the quality of life doesn't get better. And that's also rather disturbing because, people are still continuing to have problems here. And if we could find treatments that would work better, then we think the quality of life would improve. So I want to talk a little bit about some of the therapies that we use at this point. And we have, a lot of, really this photosensitive condition, and using sunscreens of SPF 70 or higher can be really, really helpful. You want to we use sometimes topicals, although they don't work necessarily as well as we would like. And then we sometimes use antimalarials such as hydroxychloroquine or chloroquine, but these can also cause a rash. So when they work, it's great because then we don't have to move on to other therapies. But sometimes you have to stop it because there's an allergic reaction, and then that's quite annoying. And then what this is telling you, though, is that the hydroxychloroquine probably works in 15 to 20% of people. So it's not a lot of people. But if you're in that 15 or 20% and it's controlling your disease, it's great. And you don't have to move on to the other therapies that we're going to talk about. We also did a study where we looked at quinacrine, which is another antimalarial in the same category as hydroxychloroquine, but with somewhat different properties. And we found with this drug that about half of patients respond, and when they didn't respond to hydroxychloroquine. Unfortunately, it's very hard at this point to get quinaquine for a lot of different reasons, which we could talk about later. But if you were able to get it, it could be helpful. And we do find a lot of skin reactions with hydroxychloroquine. And so what happens then is people have to go on and often get immunosuppressives or IVIG or both. So this is a study we did with quinaquine. And these were people that were before they got quinaquine with their dermato. And you can see that the patients in blue got better pretty quickly after getting onto quinaquine, but there was still plenty of people that were still had the red that didn't get better. And so, but the people who got better, it was also very helpful. So second line therapies, if the topical sunscreen and antimalarials don't work, it could include immunosuppressives such as methotrexate, mycophenolate mofetil, azathioprine, cyclosporin, tacrolimus. And we're talking about the skin here, but this is often used for other parts of dermato, such as the lung, the muscle, or the joints. And so whenever we think about treatment or evaluate treatments, we want to be able to think about, well, which one makes the most sense depending on what organ is most affected, and finding one that will help all of the organs is really, I think, critical. Steroids are needed for a lot of patients early on, especially if they have muscle or lung disease. We occasionally use it as a bridge for till we find a different therapy that works in terms of the skin. But they have a ton of side effects, and what we're going to talk about in terms of hopefully new treatments would be really helpful to be able to get away from having to use glucocorticoids. IVIG, as you probably know, was just approved by FDA a couple of years ago, and we know it works. There was a great study, I'll show you the results, that showed that it works. Tofacitinib in a 10-patient open-label study seemed to help patients who have predominantly skin disease. And that still has not been studied in a trial, but it could be helpful for some patients. And then rituximab seems to help people who have refractory muscle. I think it's a little less clear in the skin. But sometimes people are getting that, and sometimes for the lung as well, and also tofa for lung and as well. So here this is showing you two drugs that are commonly used for skin, mycophenolate and then methotrexate. And what I'm showing you is that maybe half the patients in each group get better. The blues are getting better, the reds are not, or not as quickly. And what this is showing you, though, is that when a drug starts to work, which hopefully it does early on in the first few months, it can continue to get better and better in terms of the effect on the disease. The disease gets better over time. And this is great. And the same thing we saw with methotrexate, that, there might be a rapid response, but then you can get a gradual improvement over time. And this is important. However, it also means that when we design trials, it's really difficult because these background medications may have effects on the placebo group, which make it very hard to show a difference between a drug and the background medication that is more the standard of care medicine. So this is the IVIG study, and here what this study showed was that there was this is something called a TIS, a treatment improvement score, and you can see here that with IVIG there was quite a bit of improvement relative to the placebo, and then starting at 16 weeks, everybody got the active IVIG, and the people got placebo really kind of caught up with the patients who had gotten drug all along, and you see a leveling off of the effect. So what this tells us is that a lot of patients, really got better. Some of them got better quite quickly. And so it really lends the rationale for the use of IVIG for treatment in dermatomyositis. Now, we did also recognize, though, that since the people involved in this trial, the patients recruited all have muscle disease. What that means now is that sometimes it's not as easy to get IVIG for people who only have skin disease, and emphasizes the importance of including those skin patients in trials so that we can be able to access new therapies for everybody, not just the people who have muscle disease. So that brings me to talking about some experimental therapies, which we've spent a huge amount of time doing this work in the last few years. One of the studies was Lenabasum, and we'll talk more about that. And then another trial we've been very involved with is the anti-interferon beta. And I can't talk about the results today, but actually some of the results will be presented next week or actually this week, later in this week, at the American Academy of Dermatology meeting. But I think we're going to find some really interesting results that have led to the development of a phase 3 trial that is right now only involving muscle patients, which I hope doesn't limit the ability to use this drug in the future for skin. So Lenabasum is a synthetic selective cannabinoid receptor type 2, CB2 agonist that activates the immune system in a way that suppresses secretion of these inflammatory proteins we talked about before, such as TNF and the type 1 and 2 interferons. We also know IL-31 is an itch cytokine, which is also affected by Lenabasum. And we've done some work in vitro to show that this actually inhibits the production of these proteins by stimulated cells. So here, this is looking at what happens. This is looking at interferon beta. And you can see that there's a lot of it there when you stimulate cells. But when you add Lenabasum, the interferon beta, which I showed you before, is an important protein in the skin, is going down in cultured cells that have Lenabasum. And the higher the concentration, the lower the interferon beta is. So this was very interesting preliminary data. And we went on and did a phase 2 study at Penn with 22 patients that were randomized either to get placebo or control. This is actually the placebo, and this is the treatment arm. And one of the things when you look at a study is trying to understand, why does this look this way? And so I will tell you that at the beginning of the trial, in the first 4 weeks, this is 4 weeks of the trial, that the patients got half the dose of Lenabasum that they got starting at week 4, where they got double the dose. And so the placebo arm and the treatment arm completely overlapped at the beginning of the study. And then as time went on, you could see the placebo group just completely leveled off, and the treatment arm got better and gave a statistically significant difference in the outcomes in the skin in these patients who predominantly had a myopathic dermatomyositis. So this is the kind of response that we saw at the beginning. You can see the patient is quite red. The skin is quite red on the arm, on the chest, and much better by week 12. And we had a number of patients who really benefited from this study, which then became an open label study. So everybody got the drug. But in the first part of the trial, what you can see here is that when the patients, this is really important, rated their own skin activity, you can see that they thought they were doing better relative to placebo, that the symptoms got better relative to placebo, and that the pain that was in the skin got better relative to placebo. So it wasn't just about the skin activity, but it was also about the patient-reported outcomes, which is really so important. That was also shown to be improved with this drug. We went on in my lab, and we did a lot of studies looking at different cytokines and that were in the skin that we think are important drivers. This is looking at beta and gamma. And what this is showing you is this is at the beginning before treatment, and then after 3 months of treatment. And a lot of the interferon beta and interferon gamma, you can't really see it as much after treatment. Whereas in the placebo group, it's still there. And we were able to quantitate this and show that there are differences in these proteins that are driving inflammation in the skin between those who got drug on the left and those who got placebo on the right, where there was not as much of an effect. So we went on and did almost 3 years of a long-term extension to show the safety of the medication and also the fact that it continued to work and continued to improve. So here you can see that the open label extension, this is what happened here is this is the randomized part of the trial, which, as I told you, was 4 months. And then everybody got drug, and you can see that everybody did a lot of people, not everybody, did quite well with drops in their skin activity. And then this is looking at symptoms, and similarly, getting better, and over time staying down. And it was very well tolerated. So what happened after that is that there was a phase 3 Lenabasum trial, and that ended about, actually now, it's sad to say, almost 2 years ago. And the primary endpoint, and this is because of the FDA, they like something called an investigator global assessment, which is very insensitive to the changes in skin. And so what's happening is a lot of the trials are using the treatment improvement score, which is more of a muscle measure. And so what this is telling you is that the primary endpoint wasn't really met with the TIS score. And that although there was maybe some improvement in people who had more muscle weakness, and there was some improvement in those who had an activity score, who had more skin predominant. So if you want to actually look at the scores, so this is looking at the treatment improvement score between, this is looking at the Lenabasum and placebo. And so you can see with Lenabasum, it was a little bit more of a treatment improvement, but this is not much of a difference, and it didn't really change over time, maybe a little bit more by the end. So if this is looking at everybody in the study, and there was a lot of patients actually that were in the study. And then here we're looking at what happened to the skin score. And again, not a significant difference. The p-values are not significant down here. And so this is looking orange placebo and blue is Lenabasum. And what you're seeing is there's a little bit more of a drop with Lenabasum, but it wasn't as much as what we were seeing in the phase 2. So this is looking at the patients who were weak. And again, you can see there's some separation, but placebo, a little bit less improvement, pretty big placebo effect. And Lenabasum a little bit more, but not really statistically significant most of the time points that were looked at. And then this is looking at people who had only skin. And this really looks very similar to the data we saw in the phase 2, which is that the placebo arm, nothing really got better. But this is looking at the change in the skin score. And you can see these are very significant improvements in skin score in the people who had skin predominant disease, amyopathic DM. And it became statistically significant already by week 28. So to me, what this is telling us is that if we had been able to take patients who had more skin predominant disease and use a validated skin score, this drug would have been found to be effective. But by virtue of having to include muscle patients and not being able to capture the changes much, that was a problem. Now, this is what the tests look like in the MMT 150s, and you can see that there's improvement, but it takes much longer to get about 52 instead of 28 weeks to see the p-values that are significant. But even with this, we did show a difference in the skin patients by the end of the trial. We've gone on and we're continuing to do a lot of studies with Lenabasum, trying to understand the cells that have CB2 on them, what percentage of cells have this receptor that is downregulated and causes the improvement in the immune system. And so what this is showing you, though, is that when you look in the peripheral blood at the same cell as what we found in skin that we actually eluted these cells out of the skin, there's much more CB2 in the skin cells than in the blood cells. So there may be something about the local environment in the skin that upregulates a receptor that makes people more responsive to Lenabasum. And we were using, again, that multiplex flow cytometry. It's a way of looking at many cells at the same time and finding these interesting differences. Now, there's a number of ongoing and future studies. The anti-interferon beta is being reported out this week and is going to be a phase 3 trial in the near future with muscle patients only. The Hizentra trial is a sub-Q IVIG, which is skin and muscle, or skin only, and that's in a phase 3 trial that's still ongoing. I will mention the TYK2 inhibitor VALOR study, which is going to be beginning or is beginning. They've enrolled some patients. And this is another approach to downregulating the type 1 interferons that are in the skin and in the blood and in the muscle of patients who have dermatomyositis. And so this will be a very interesting study that's right now going to be muscle patients. And there are many other studies in the pipeline. And so I think this is really going to be in a very important time to find the therapies that are most effective for people who have dermatomyositis. So in conclusion, dermatomyositis is frequently skin predominant, and we do have now better classification that does include amyopathic DM, but we're continuing to work on this. We're learning more about pathophysiology. We're looking at looking for systemic disease and how often we see that in patients who have dermatomyositis. And the treatments are being looked at very carefully to try to understand better what our standard of care therapies do and are they working and how many people do they work in. And then you saw some of the studies that we've done with antimalarials and IVIG is really important and with immunosuppressives. If there's a take-home message, it's to avoid immunostimulatory herbs. We've seen an awful lot of people who've started taking these and have developed dermatomyositis. Validated disease severity tools are available now and helpful. There's several potential therapies in development, which I think is going to be incredibly exciting and important. And we need to think about including amyopathic dermato in future studies. I want to acknowledge a lot of the funding, including from the Myositis Association that I've had, and this has been really instrumental in letting us do many of the studies that I've talked about today. And I've worked with any number of students and fellows over the years that have been really important in helping move this field along. And so with that, I'm going to stop sharing and hope that we can have some questions and discussion. Thank you very much.
All right, thank you. Let me add my spotlight. All right, we've got a few questions in the Q&A and we have about 15 minutes. So get your questions in. We also have some that were submitted before the talk. And before I forget, thank you so much for doing this. We really appreciate you, Dr. Werth, and sharing your expertise. So let's get into it. Are you aware of Gamunex C being used for DM? It is administered by IVIG or injection. Is it ever used as injection for DM? Medicare is wanting this person to switch from Hizentra, which does work well for that person, to Gamunex.
As far as I know, Gamunex is a form of IVIG, and I might be wrong about this, but as far I think Hizentra is the only sub-Q variant of IVIG, and I would say that the amount that you should need to use is quite large when you do Hizentra, if you're going to get the amount that is typically given with IVIG. And so the way it's done in the study is there are pumps that are used, and you can actually give the IVIG multiple times during the week, and so you don't get the same dose, so maybe not quite the same side effects because you spread it out and it's done each week. But I'm not aware of that, and it's a great question.
And in the same vein, you may not be aware of this particular question because it might need a Medicare expert, but they're wondering why Hizentra is covered under Part B Medicare and not Part D.
Oh, yeah,
yeah. That's what I thought, but I thought I would ask just in case.
Yeah.
This person would like you to explain mycophenolate TAB. Pros and cons.
Explain. I'm sorry. Say it again.
Mycophenolate, and then they put TAB, which I don't know if that's tab or.
Yeah.
They just wanted to know the pros and cons of that medicine.
Okay. So, there's a number of immunosuppressants that are used for dermatomyositis, and I think it's important to know that what's chosen varies a lot depending on the patient and on the provider. But for instance, some patients that I have don't want to give up drinking alcohol, and so they can't take methotrexate, and so we give them mycophenolate. Some people don't respond to methotrexate, and we give them mycophenolate. Some people have lung disease, and I think mycophenolate probably works potentially a little bit better than other immunosuppressives for lung disease. So, the pros and cons are so individualized depending on the person, their who they are, what they want to do with their lives, and what organs are involved, that it's really difficult to say. But I think mycophenolate can be really beneficial for a lot of patients.
Thank you. This person has a question about discontinuing IVIG. They have hypomyopathic and they responded to IVIG well, but lately their derm has been trying to wean them from IVIG, increasing frequency between infusions. And now they're flaring, treatment transformed panniculitis in terms of skin flare, plus some sensory neuropathy type issues. So how long can someone stay on IVIG? Is there really any urgency to wean off of it if you're only going to have to start some other maintenance med, especially if it's going to be an immunosuppressive?
Yeah, I mean, there are people that are on IVIG for many, many years, if not decades. And especially for people with malignancy, where you absolutely do not want to suppress their immune system. I often will manage people for long periods of time with IVIG, but other people as well, who are the other therapies aren't working, or maybe they don't want to be on an immunosuppressive. And IVIG, when they can't stop it without their disease coming back. It's not a cure. It controls the disease for many patients, not all, but they're definitely for the right patient, it may be something that can be a maintenance.
Have you ever used LDN for DM?
LDN.
I don't know either. If you don't know, I definitely don't know.
Acronyms and me don't get along. Whoever wrote that, can you write down what you mean by?
Yeah. Can you
low-dose
type in?
naloxone? I think it's I have not. I've had some patients who've used it, and they've actually been bad enough that they've enrolled in studies after doing that. We don't have studies. So I think for individual patients, maybe it helps. And there's some literature about it being helpful in autoimmune disease. It's naltrexone, right? Low dose naltrexone. But anyway, it's not something that we routinely are giving.
Okay. The next couple of questions are about diet. This particular person is concerned about the creatine kinase level, CK level. Does diet play any part, and how can we reduce?
So CPK levels can vary a lot from person to person. And if you exercise, it can be high. If darker skin, African Americans have higher CPKs. And in and itself, it doesn't mean that it's a bad thing. But if you have symptoms with it and you have muscle weakness or pain, then it does take on significance. But typically, the food is not a reason it's not a reason to not eat the certain types of food. It's really more of a marker for activity of the disease itself.
Okay, and this next question is about eating a certain type of food. They are asking about elderberries. Are you saying they should never be eaten by DM patients?
I never say never, but if you read about elderberry, it will tell you about how the peripheral blood mononuclear cells are stimulated, and it is one of those immunostimulatory herbs. We've seen some people who started using it and end up in the hospital with dermatomyositis. There's not enough data, I think, to say you can't use it, but if you have the disease, I think you want to avoid things that potentially could be a problem.
Hopkins cites garlic as an immunostimulator, I can't say that, problem for lupus. Do you see this as being true for DM also? She says, I'm not talking about garlic used in a recipe in moderation, but people eating raw garlic, especially regularly. Yeah,
I have not seen that as an issue. And what I would say there is for individual people, there are, they talk about this a little bit in some other autoimmune diseases as well. And I always say if you, eat something and you notice that it's associated with a flare, then maybe that's telling you something. But I don't tell people to avoid garlic.
While we're talking about food, this person that wrote in is asking about, let's see, is there any research between food and DM symptoms, for example, SIBO and skin manifestations or dysbiosis?
Yeah. So they're talking about bacterial overgrowth and whether that's somehow related. I'm not aware that there's anything like that, but I'm sure that there is a bowel gut skin connection. There are for a number of diseases, and I suspect there is for dermato, but there's not enough data right now to be able to say too much about that more than and I don't think that there's a reason to treat bacteria in the gut unless you're symptomatic. There is actually, along those lines, a microscopic colitis that we see in patients with dermatomyositis, and we did another study that we published about this. But it's definitely increased, and a lot of my patients have microscopic colitis. Some of whom have had, they've had colonoscopies and biopsies, and that's what they're told. And that's important to realize that can be part of the disease. And sometimes the therapies that we're using for other parts of the disease can be helpful for that as well.
Thank you. Is it typical for myositis-associated antibody levels to decrease after azathioprine treatment? Additionally, what's the typical response time to azathioprine?
Yeah, so azathioprine is, I think, particularly good for muscle and possibly lungs and joints. I don't know that it's as good for skin. So the response time is similar to what we see with methotrexate or mycophenolate, but we have not studied it as much because we don't use it as much in skin. So that would be one comment. And then what was the other question with that?
I moved it over.
Oh, let me think if I can remember. Yeah.
Oh, what? Yeah, you said are my associated antibody levels.
Yeah. Okay. So
Mhm.
the antibody levels, we tend to not necessarily repeat them. I mean, they're used for diagnosis. They're used for potentially phenotyping patients. I'm sure that some of them do respond. And there have been some correlations, for instance, of high titers with certain manifestations. But so far, given the problems that we have with the low prevalence of antibodies and the different technologies, it's not something that, in general, there have been some individual studies where there have been things have been looked at, but not enough to be able to really make any definitive statements about fluctuations. It's more for diagnosis.
Can small fiber neuropathy occur from a myopathic myositis, specifically in the hands and face?
And face, you said? Yeah, it's usually hands and feet. Face would be a bit unusual, but definitely we see a lot of people with small fiber neuropathies. Yeah.
Can a myopathic dermatomyositis cause appendix rupture, colon resection, joint pain, and early cataracts, specifically posterior subcapsular cataracts?
So there you're talking about side effects of medications. I talked before about how much we hate steroids and how we want to eventually get to a point. My goal in life is to eventually not have to use steroids at all, but they do cause subcapsular cataracts. That can cause all kinds of perforations. I don't think they would cause appendicitis, and that can just happen on its own without any kind of underlying dermato. But the rupture, that can happen. Steroids can weaken the gut and you can have ruptures. So I think it's more about the side effects of the medications than about the disease itself.
Okay. What is the skin biopsy histological criteria for diagnosing DM?
That's a great question. So, and I didn't go into all my research on that either, but basically, you can't really say that dermato has a diagnostic criteria in the skin. We look for interface dermatitis. And as I mentioned, that we find the same findings in lupus that we find in dermato. So there's no specific criteria, although there are some people that will do some kind of special staining for terminal complement components in the vessel wall that might be more characteristic of dermatomyositis than lupus. And that's not a routine pathology test, and it's not something that's done in most labs. So in general, it's a test that helps once clinically that you think somebody's in a certain category, and you get that biopsy result of interface dermatitis, then you go back and look at the person, and it's really the clinical path correlation that helps make that diagnosis. You can't make it from the biopsy.
Okay, here's another word I have to try to pronounce. Are eosinophils generally present in DM skin biopsies? And if so, are they responsible for the chronic itch?
That is an amazing question. Okay. So if you talk to a lot of dermatopathologists, they would tell you you don't see eosinophils in the skin in DM. However, we've done some studies, and we actually know that there's a few patients who even have a lot of eosinophils and even spongiosis, and but they also have interferon, which we don't see in like eczema, which is where you might expect to see that histology. And so we do see EOs. We see it's a type of cytokine called Th2 that can be made by eosinophils. We see that in the skin. But we think a lot of the itch is coming more from IL-31, which is an itch cytokine. And we did do some work showing that there's IL-31 in lesional skin in dermatomyositis and correlates with itch. And that, but I think there are also other IL-4 cytokines that probably are derived from eosinophils that are contributing as well.
When all your labs are negative, but you have every symptom, how do you know for certain you have DM? That's kind of a general question,
Yeah,
but
but it's a great question because it comes up every day for me. And
right.
so, a lot of times, and this is frustrating for patients and for physicians, you'd love to have a blood test that says you have dermato. As I showed you, most people don't necessarily have that. So it's more a matter of looking for the clinical findings and really trying to see as much as possible. Is there anything going on in the muscle with an MRI or EMG? If the muscle enzymes are abnormal, if there are muscle symptoms, if the skin is really not showing enough, but there's certain findings that can be clues, then a biopsy might be helpful. It's really a matter, and some people you don't know for sure, and then it takes time. And over time, they become more, declares more what's going on. So it's very frustrating. It's also frustrating not to get the diagnosis, which I think is incredibly common as well.
Yeah. And the second part of that question was, what else could it be? Which it seems like that would be a wide net.
It's a huge net. There's a lot of things that can look like autoimmune disease or dermatomyositis. And, I think you just have to look again, do the clinical path correlation and look for the clues. But in terms of other, I showed you some examples. You could think about psoriasis. You could think about eczema, lupus. All the things I showed you that were the diagnoses that were not what the people with dermato had are the undifferentiated connective tissue disease. There are a lot of things like that can be mimickers or can look a lot alike, and you really have to get the biopsy and do the clinical path correlation and really think through what is going on here.
We have just a few questions left. I just started CellCept and I read that it takes 6 months to a year for it to start working. Is this true? And if so, what do you advise your patients to do in the meantime?
Yeah, so I showed you some data that shows it can work quicker. And I think it can often work starting within 2 months. If you can try topicals, if the CellCept's not working or the mycophenolate's not working yet. And some people that are really severe, we may give them IVIG for a period of time while we're waiting for the drug to kick in, and then try to taper off the IVIG. Because IVIG can be inconvenient for some people, and it can be not tolerated. And so, but it can be okay as a bridge drug while you're trying to get the right drug that's going to work.
We had 2 questions come in about dry, thickened cuticles and how to treat them.
Yeah, that's definitely a hallmark. One thing is to put topical steroids on the proximal nail folds to try to decrease inflammation there. And then other than that, I think just using Vaseline and moisturizers that can help lubricate the area, maybe like Hydrin, if there's scale there, that can help also remove some of the scale. But it's a very common problem.
Okay, and our last question is, I have had this dermatomyositis for 30 years. What is the best way to treat it without prednisone? Creams, shampoos, and what about muscle weakness?
So, the question there would be kind of what organs are involved, because creams aren't going to help the lung, they're not going to help muscles, they're not going to help joints. If it's just skin, then very often, and I don't mean just skin to say it's trivial, it's not trivial at all. But you can try, with things we've talked, I really kind of went through the whole litany of what we do with hydroxychloroquine, methotrexate, mycophenolate, which, and often the patients don't have to, if they're just only on skin, may not need steroids. We try other things, but sometimes if it's bad enough, then you really don't have a choice.
Do you have any final words to share with us? What do you normally tell your patients as they're grappling with this diagnosis? Well,
I think being involved with support groups can be really helpful, just to be able to bounce ideas off of people and who are sharing the same problems that you're sharing. Finding the centers where you live where people focus a little bit on dermatomyositis can be very helpful in terms of trying to come up with some of the newer therapies, and seeking that out, because there's really going to be a lot of trials going on, and there's a really big need to get new therapies, and the only way we can get those is with trials. I would say, as things come up about the FDA, we have a lot of work we need to do with the skin part of the FDA that's really kind of causing a lot of problems right now for new drugs for skin. But I mean, my advice is really just, to get as much knowledge as you can, find experts and to find people that can be supportive.
Thank you so much, Dr. Werth, for being here. We appreciate you. And thank you to those of you in the audience.
All right.
Please tune in to our next webinar, which will be Ask the Doc with rheumatologist Dr. Leslie Sackett-Koo. That will be this Thursday, March 16th from 6 p.m. to 7 p.m. Eastern Time. And also, those of you that are listening in that have DM this month, we have a Living with Dermatomyositis Empowerment Clinic with Dr. Julie Peck and TMA Community Ambassador Shauna Nielsen. That airs on Thursday of next week, March 23rd from 6 to 7 p.m. Eastern. Hope to see you then. For TMA, I'm Rachel Brownlee. Good night.
Bye-bye.